Welcome back to the Shared Practices podcast. This is season 4 on case acceptance. We have another episode today from Voices of Dentistry with Dr. Martin Mendelson. And before we get into the episode, I just want to say thank you to all of those who have submitted video testimonials for our contest on Facebook. And by the time this episode comes out, we'll have announced the winner on our Facebook page inside of our Shared Practices group there. And that winner is going to get tickets to next year's Voices of Dentistry. I think it's around $500, kind of average. I don't know if it's at the cheapest, but the average registration price for that is about $500. So super grateful for all the work that you guys did and for those who shared those video testimonials. I will say one lesson I learned is that it is really easy if someone comes up to you in person and says, "Hey, I loved your podcast," or "This meant X, Y, and Z to me," or "We bought a practice because of this." It's way easier to turn around and ask that person, "Would you mind if we did a video testimonial of this because you loved it so much? Because, I want to share that experience with other people and capture this moment," than to ask them digitally later. And I think that lesson applies to getting video testimonials from patients is if we ask patients in the moment that they're super happy about being at our practice, or they express that how much they love our practice or how comfortable they feel there or the results of their care, that is the moment to ask for that video testimonial, not a month later, not in an email a week later. So that was one of my lessons learned from this is we got probably 4 or 5 responses from people who sent in digitally some videos, which I'm super grateful for. We also recorded about 4 or 5 of those in person at Voices of Dentistry. So it's a lot of work and effort to record something and put it out there. Just ask in person is what I've learned. So without belaboring this too far, we'll get into this interview. Dr. Martin Mendelson, this is a shout out to our specialists. So we've done a whole season on case acceptance. Some of it applies to being a specialist, some versus being a GP. And I wish we had more content on our show that applied to specialists like perfectly. A lot of it kind of has to be adapted. I met an orthodontist at Breakaway Dental Practice, and she's like, yeah, 20 to 30% of it just kind of doesn't apply, or sometimes even more, but you adapt the rest of it. So I feel bad. I wish there was a shared practices for endodontists, and then there was another one for periodontists, but it's just, for us, not feasible at this point. And it's also, I'm not a real specialist. I'm a fake specialist through the Army. So, but this episode, we talk about case acceptance for specialists and for GPs working with a specialist, and how increasing that relationship is going to help both sides. Both providers, the specialist and the referring GP, are going to see more and do more and have better quality interactions and relationships with patients, which is just going to lead to better treatment outcomes and more treatment that's done. So we will dive into this interview. I hope you enjoy with Dr. Martin Mendelson. One of the advantages of working with Blue Sky Bio's implants is that if you're already familiar with a given system, whether it's Nobel Active, Nobel Replace, Zimmer, Straumann, Astra, it's really easy to make the switch because you're very comfortable and familiar with that system. You have the drills, you've placed those implants before. But what if you're new to either implants in general or to Blue Sky Bio and you haven't used any of those specific lines? Which one of the 6 lines of Blue Sky Bio implants would you choose? Which is a great question. So let's go back to the Facebook forums. The overall consensus, hands down, is the BioMax line, which is the Nobel Active compatible system, but with a narrow platform, single platform across all of the different implants. Meaning, if you go up in size, you keep the platform the same. What this does is it simplifies your inventory, makes life so much easier. So people were saying, can you get locators for BioMax? And boom, locators, we got locators. How about scanning? If you want to scan this into CEREC, take a tie-base NBA 4.5, and that's it. That one tie-base will work for all sizes of the BioMax line. And then the advice when it comes to actually placing the BioMax line of implants is to place them just slightly subcrestal to give yourself room to get that emergence profile and the aesthetics and everything looking just right. So if you were hesitant to try out the Blue Sky Bio implants because of the plethora of options, you were just overwhelmed as to where to start, That is the hands down consistent number one choice of clinicians who are placing and restoring these implants in their offices. Biomax by Blue Sky Bio. I have with me today Dr. Martin Mendelson from Spear Education. And this is really exciting because I feel like we have gotten requests, and we definitely have gotten requests from specialists and GPs who want to do bigger cases and get bigger cases accepted by their patients. And they've struggled with finding materials of how do we work together and increase the case acceptance all the way around. So I want to welcome you on the show. Welcome to...
Thank you very much. I appreciate it.
This is at not Dental Hacks. We're at the Dental Hacks booth here at Voices of Dentistry. And so forgive the background noise. We tried to quiet it down.
Yeah, there's a lot of catering going on.
There is catering. There was music. I didn't want to get sued by the companies for playing some music in the background.
You shut that down, so kudos to you.
Right.
Yeah.
So tell us how you got involved in Spear. I think a lot of people see Spear as kind of this pinnacle of clinical education. And so to be able to kind of be involved in that is exciting and enticing, something that a lot of people might appeal to them. So what was your journey to get there, and what do you do for Spear now?
Sure. Well, thank you, first of all, for having me again. It's a lot of fun to be able to kind of share practice growth and case acceptance and the two sides of the coin.
Yeah.
I can't believe it, this year I'm going to be at Spear 8 years.
That's awesome.
And it's been quite a journey to get here. I am a GP by training.
Okay.
Went to the University of Maryland and practiced outside Baltimore for about 10 years.
Okay.
Then became disabled from dentistry. I ended up with problems with my hand.
Oh, bummer.
And so, had some lemons and made lemonade out of it. And I ended up working in a dental laboratory for several years, learning the communication between the dentist and the laboratory. Then from there, was fortunate again and was hired by Vita in North America and oversaw their education and their key opinion leader program.
Okay.
And did that for about 5 years. And then, as I said, about 8 years ago, I came to Spear.
Okay.
And so my main role at Spear as a member of the resident faculty is to engage both with our study club leaders as well as our master's program participants. Our master's program launched officially about a year and a half ago, but it's actually been in development for several years now.
Okay.
Which is to help oral surgeons, periodontists, and endodontists have better and deeper relationships with the GPs that refer cases to them.
Cool.
So that the GPs can have a more productive and successful practice, which of course is better for the patients and better for the specialist.
Yeah, no, absolutely. And that's one of the things I'm really excited to talk to you about is that perspective of helping and coaching specialists in building those relationships and increasing case acceptance.
Yes.
But let's look at the flip side here of GPs who decide, I want to get more involved in comprehensive care.
Sure.
And they realize, maybe they're a little bit naive like me. So I decided to do a 2-year residency with the Army.
Mm-hmm.
And in dental school, I thought I wanted to do everything.
Sure.
And naively thought I could be good at everything.
Sure.
And it took like a solid year into this 2-year residency to realize you will never be as good at any of these subset of procedures as the specialists who are, the experts in this.
Sure.
And maybe I can get pretty dang good at a couple things that I love and work on. But at the end of the day, with all of the training, I gained a deep respect for the deep knowledge and experience of these specialists.
Sure.
And especially the setting that we were able to treat complex cases, where in residency, we would present our cases to a board. We'd get grilled by board certified specialists.
Absolutely.
And held to a very high standard, which was very stressful. But
stressful and an amazing experience for you to be able to have that at your disposal as part of your learning experience.
Totally. Yeah. And in the end, I now have a smaller subset of okay, I really want to do molar endo, onesie, twosie implants, maybe someday, building up to a little bit more. Mm-hmm. I like wisdom teeth. I like surgery. And I have a smaller skill set that I really want to develop and take further.
Sure.
But now I can see things that I didn't see before.
Yep.
But talk to me about that. How, maybe if a GP thinks I want to do comprehensive care and I want to go to Spear, maybe I want to learn some more, do bigger cases. Mm-hmm. But then they also realize I'm not going to be able to do all of this. And so I have to refer a lot of that out.
Sure.
And it kind of feels weird. It feels like you're going in the wrong direction. You're building these cases up to then ship them off, to these specialists. So talk to me about how that assumption? If someone was afraid of that, what would you tell them?
Sure. You're making the coach part of my persona kind of come out, because there's all these limiting beliefs that we all as people, and particularly as dentists, have about, I need to do this, I need to do that, or I can't do this and I can't do that. And the reality is, particularly for those that are newer out in our profession, those that graduated, last year up to, 10, 15 years ago, the amount of debt that the typical individual is coming out with is, $300,000, $400,000, $500,000 as a GP.
Yeah.
Then you add on, if you choose to start your own practice, then you tack on a couple 100,000 or more.
Yep.
And so there's actually a lot of pressure on the GP to actually be productive and successful, which is where some of this stuff kind of percolates in.
And there's this kind of territoriality of like GPs who want to do more, and specialists who are trying to make things work.
Yes, absolutely.
And finding a way to work together can be stressful, maybe.
It can be very stressful. And, one of my favorite things that Frank Spears ever said is, you only treatment plan what you see, you only see what you know.
Yeah.
And that is so very, very true. And that has to do not only with just the treatment planning process itself, but even the how the actual literal clinical, the case itself flows, first, second, and third. And so the reality is that understanding that you can't necessarily be the jack of all trades.
Yeah.
And that if you engage with your interdisciplinary team and you broker a really good relationship with your oral surgeon, your periodontist, your endodontist, your orthodontist, the knowledge that you will then be imparted to be able to identify how to actually progress within those comprehensive cases will skyrocket. You'll learn which cases I want to keep in-house, which cases I want to refer out. And those specialists that are open-minded, which is most of them, that really want to help you be better because it helps them when they help you, they end up being more successful as well. Because the reality is that, let's take implant placement, for example. There are many GPs that have chosen to place their own implants, and that's a trend that's going to continue. But here's the reality. The reality is you need to learn how to do that. You have to have the right armamentarium to do that. You have to understand how to do it, what's going to happen with complications, and understand what your limits are. And all that takes time and, frankly, money.
Yeah.
Whether we're talking about the armamentarium or the knowledge. Whereas if you partnered with your surgical specialists, you let them handle those surgical elements, increased your predictability in the restorative aspects of those placed implants. Now, all of a sudden, if you actually take a look at your practice from a business perspective and you look at production per hour, now all of a sudden you're becoming all that more productive per hour because you're doing what you do best, which is the restorative elements. So there's a lot to be said about the power of the interdisciplinary team, not just from a treatment planning perspective, not just from understanding what you choose to do or not, but also from a profitability perspective on the part of the practice. Because the reality is that pick whatever topic you want to pick from a specialty procedure perspective, 9 times out of 10, you're not going to be as productive doing those as the specialist would, because they just have the infrastructure to support it.
I mean, it was amazing to me in residency how much faster my molar endo would go when the endodontist, my actual mentor's assistant, was assisting me.
Exactly.
Because she was so much more efficient than my assistant was at endo.
Yep.
And so like it just finally like dawned on me and kind of sunk deeply in that, you know what, unless you truly specialize, that is the name of the game.
Yeah.
You're not going to hit that peak or that pinnacle of efficiency and productivity. So, but at the same time, in this season, we've talked about diagnosis and case acceptance.
Yep.
Because if you can improve both of those, then you're going to do a whole lot more dentistry that's good for patients on the same patient pool.
Yep.
So talk to me how diagnosis, that's something that's like, it sounds kind of weird. Like I want to increase my diagnosis. How can working with a specialist help a GP increase their diagnosis, or working with Spear, either way?
Yeah. So if I understand your question right, it's how can they increase their diagnosis, and therefore how does that filter into case acceptance as well?
Well, and I see them as two different dials.
Mm-hmm.
It's like if you see more and diagnose more, and then you also are better at the case acceptance process, if you improve both of those, your overall improvement is going to be a lot more significant.
Agree 100%. And I would say there's a heck of a lot of overlap between the two.
Yep.
So let me give you an example.
Okay.
In our study club platform, the way we coach the study club leader to launch their study club, if you will, is that the very first meeting of the club itself, once the club is formed, the video, the module, as we call it, is called Study Club 101. And Dr. Spear on the video actually guides the group to think about, okay, so what do you want to get out of this experience? And what are your expectations? We then guide them a little bit deeper and turn that purely into a clinical discussion and think about what are the key case types that you would like to treat in your practice, treat more of, or potentially treat more comfortably. Okay. So you're first identifying, you're becoming self-aware of what those areas are.
Okay.
That then leads into a really awesome experience where we provide the structure and the guidance at the beginning of this process, where you sit down with the specialist and or specialists that are within the club, and you literally talk about the kinds of cases you would like to treat moving forward.
Okay.
So even if that case isn't necessarily of an active patient, it'd be a patient of record, of course, but maybe you're thinking about doing a pro-arch case, okay? But you've never done one before, you've only done one of those. So you bring that in, and all of a sudden you walk through that process with the surgeons. You understand it at a deeper level. Now, all of a sudden, the next time one of those patients come in, let's say with a terminal dentition, you're much more adequately able to diagnose the condition, determine where you want to go. And by truly understanding that at a much deeper level, your communication increases, or shall I say, becomes more effective with that patient so that they understand what their current situation is, what the next steps are, and then how to proceed. So that diagnostic acumen, that diagnostic understanding really flows into the communication elements. And frankly, one of the things I'm most excited about is the fact that we now have not only a patient education platform, but it's a patient education app. And the application is for either Apple or Android. And the reason why it excites me is the way it's designed, because I want you to picture this for a minute. You're sitting there, you're talking to a patient, and you want to explain to them the condition, the missing tooth. Now you have at your disposal these animated videos that you can communicate with the patient. You can pause the video. You can talk to them about their specific condition. You can draw on it. You can write on it and then text it to them right from the chair. But the reason why that excites me is in the data, because what we know, having worked with our several hundred clients in our practice solutions arm of Spear with our GPs, those that actually use those videos see a 10 to 20% increase in case acceptance.
Okay.
And that has everything to do with what? With communication.
Right.
So it all kind of ties back together.
So I'm trying to figure out how, Adam and I talked about applying this and using this and some examples of it, but the ability to write and send a message, how new is that?
That element of the app, that's brand new.
Brand new.
So the app itself launched, late last year, December-ish. So we've had patient education for a while as a desktop application.
You say last year, 2017 or 18?
18.
Okay, so the app as a whole is really new.
The app as a whole is new. The videos on the app are not new.
Okay.
Those
existed before.
Correct.
That's okay. So I talked with Adam about it when there was the videos from the online platform, not the app yet. Did you say that you can put patient photos in there, or not yet?
Not yet. No.
Is that something maybe on the table?
I believe
eventually?
that's something maybe on the table, but. What I want you to picture is the animations are so realistic that typically what a lot of our clinicians are doing is they're taking the photos of the patients. That's up on the monitor. You have the tablet right here. You pause it and you go, see that?
Right.
What does that look like? Holy smokes, that looks like my mouth.
Right.
So that's how you connect the dots.
Okay, cool. And so I'm just trying to think about this overall, and I'm thinking about kind of my limited journey. Everyone has their own journey, but I feel like sometimes until you've seen some of these procedures or even done some of these procedures, you just don't understand what's possible. So as a GP, the easiest way to diagnose more and decide, do I want to get into this kind of treatment, is with a local specialist.
Absolutely.
And so maybe you go on the Spear online platform and you watch some courses on it, and then you go with your specialist, you sit chairside with them and watch a surgery. And then maybe at some point you offer a patient, you know what, I'm expanding. I've learned these things about this procedure. I'd like to maybe offer a discounted rate to be able to do the procedure with that patient, with the specialist maybe at their office or something like that.
Sure.
And then you can decide. So for me, I realized I've done, clinical crown lengthening, osseous surgery, and disease control side of things, aesthetic crown lengthening, gingival grafting, using other grafts. And I've realized that like I love aesthetic crown lengthening. It's a ton of fun. I don't love osseous and disease control. It's a ton of work. And I like crown lengthening because it's like if I want some more room and I want a margin and but now I see everything. I see when there's recession, okay, we could do gingival grafting. We could do, all these different versions of how we could make this work.
Sure.
But it puts me in control of what I want to quarterback and what I want to say, I'd like to keep this in-house. I would never feel confident doing that if I didn't have the experience of doing it with a specialist and also a specialist locally that, I could also refer maybe a little bit more difficult version of this to them. So it's like, until you see and do it, you're just not going to see and do it. And on the flip side, so as a GP trying to do more, I think that relationship of doing it rather than feeling like you're going around your specialist, like you're sticking around their back and going to a course on the weekend, and you're kind of like ashamed to tell them because like you don't want to feel bad because you've been referring these and now maybe you'll be referring less of these other ones. How would you tell someone who wants to go on this journey of expanding their skill set as a GP? How would you tell them to go about that, talking to a specialist about that?
I think that's a great question. Having worked with hundreds and hundreds of specialists, I can tell you from my own personal experience that 99% of them would actually love the tenor of this conversation.
Cool.
There are those that are closed-minded and in a place of scarcity rather than abundance, but 99% are going to love this conversation. And the conversation could go something like this. Look, specialist. Listen, I've been really thinking about, I absolutely love aesthetic crown lengthening. Not really that excited about the osseous part, but I really wanted to share with you that I really enjoy this. However, I also know that I'm not going to ever be able to hold a candle to your depth of knowledge because you went to your specialty and I didn't.
Yeah.
And so I want to be able to do this because I enjoy it, but I also never, ever want to do anything injurious to one of my patients.
Right.
So what would it be like for you, open-ended question, to have a conversation with me about what that might look like to work together so that I can understand how to do the cases that we both land on would be good for my level of skill set, and then understand which of those cases really need to be referred because they're better off in your hands, in your chair. I think that's how I would open up the conversation.
Cool. No, that's awesome. And I think that the way that you said that and open-endedly, and so this is my favorite thing is to on air show how bad I am at listening and applying what you've just told me. Okay, so let me try and do this back to you. So let's call it periodontist. So periodontist.
Sure.
I really enjoy surgery and crown lengthening and I've seen how much fun this can be for a patient to see that transformation and realizing that it's very much in their grasp to solve this problem for them. I want to be doing more of this. However, I'm not a periodontist. I haven't been to perio residency. You have a depth of knowledge and experience around this that I know that like, unless I go and become a periodontist, I'm not going to have.
Right.
How would you feel about having a conversation about figuring out which cases and looking at cases with me that maybe I could expand and learn and do some, but also which cases would be more appropriate for you to handle and so that I don't get myself in too deep? Is that something you'd be willing to kind of talk about and figure out?
Yeah, I think that's great. I love what you said. How would you feel about having the conversation? Because what you said was not, or rather what you asked was not, how would you feel about me doing it? What you said was, how would you feel about us having a conversation about it?
Right.
And I think that was really, really good.
Okay.
Because it opens up the door for that periodontist in this example to answer whichever way they feel most comfortable. And as that relationship deepens and as that experience starts to manifest itself, certainly I know many of our specialists are more than happy to do co-diagnosis in your office or their office. They're happy to have you be in their office for what we call an over-the-shoulder experience, cool. i.e. watching them do what they do. And that is incredibly eye-opening. Watching a specialist that you trust and respect communicate with a patient will teach you so much.
Yeah.
Because it'll make you understand not only how they communicate, but how they communicate complications, how they communicate, how the patient will feel after, all those various things. And then the over the shoulder is a really key part because then as they talk through, whether it's with the patient right there or afterwards, it's okay. So did you notice how the flap raised in this manner? sometimes the opposite occurs. And you know what? When that does occur, I really have to sit back and I really need to consider X, Y, or Z.
Right.
So understanding the thought process, understanding what can go in a different way than planned, shall we say, is incredibly enlightening, because then that allows you to make a better decision about, you know what, this should go to the paradigm.
Yeah. Well, and I love what you said about, and I this has never dawned on me until you just said it right now. The idea that when you're doing an over shoulder like this and you're working up a patient together with a specialist, not only are you learning the clinical skills, but they've specialized in talking about this and getting the case acceptance and dealing with the complications and overcoming the objections.
Absolutely.
So having that over the shoulder on the case acceptance side of things is almost just as valuable as the clinical skills.
And the other thing I would say to you is this. Many periodontists, many oral surgeons have somebody called a treatment coordinator or an implant coordinator. And these individuals many times are the ones that actually present the treatment to the patient. And those individuals, many of them are stellar. And you would learn so much by listening and being a fly on the wall with them, particularly with your patients. That's something most GPs completely overlook. Now, you have to understand that most specialists would likely be very open to that. However, it's a partnership. And a partnership is such that, listen, you're going to be working together. And remember, your partnership extends to how the patient's referred. And so what I kind of want to share with you is this. 1/3 of the patients that get referred to specialists never show up. Period. The other thing is that I want you to think about, everybody listening here, how do you broach the subject of that patient to go see the specialist for X procedure? Do you say, I want you to go see a specialist for X? Or do you say, I want you to see Dr. Mendelson? Because what occurs, and what is very frustrating for specialists, is that you, the GP, you're actually not the one doing the referring, believe it or not. It's your front office staff. The patient goes up to the front desk. The front desk staff team pulls out a bunch of cards, and as I've come to call it, plays the card shuffle game. And they will communicate their impressions of that specialist's office, how far they are, how nice they are, what their fees are. All of this may be perceived not real. And that patient goes to a certain specialist.
So go this way.
So think about that if you were in their shoes.
Interesting.
About how you, as the GP, actually refer the patient.
Well, and it's funny because even in a situation where you might think this doesn't apply, in the military, in my first clinic, I was in before the residency. I had a year where I was in the normal clinic. And there would be stuff that would come up that would need to go up to the residency with the specialist. And stuff sometimes would get lost in the shuffle. And so every single time I had a referral, I would write up the referral, and then I would walk the chart up to that specialist. And we were in the same building, so it was really nice. But I made sure I talked with them and made sure that the patient was going to get there and that they were aware of what it was. And that handoff was really important to me because I didn't want it to get dropped or lost. For us in the military, it's lost in the system. But at the same time, in private practice, that's a patient who that relationship or that momentum, the desire to get this done, all of that can get lost very easily. Two of my good friends and classmates, Danielle and Austin Davis, have recently done a phenomenal startup. They've documented this on Dentaltown as well as on the Shared Practices Facebook page. And as of their latest update on our page, they were well on their way to breaking $100,000 in collections with a 40% overhead. And this is 3 months into a new practice. One of the companies that they have zero reservations recommending is Design Ergonomics. Des Ergo helped them fit 8 operatories comfortably into their 2,600 square foot practice. So their average square foot per operatory, when you include everything else, is 325 square foot per operatory, rather than the industry 500 square foot per operatory. This has allowed them to keep their overhead low. They have a beautiful office, and they couldn't be happier. If you want Design Ergonomics help to maximize your square footage while maintaining a fantastic flow and layout that is both economical and efficient, go to desergo.com, DESERGO.com, and use the promo code DESIGN today to get $500 off your blocking diagram and floor plan. So we've talked about, I love this. I feel like as a GP, if you want to diagnose more, and get better case acceptance, there's no better way to do it than having a specialist network that you're working with.
Correct.
Working one-on-one with specialists. You're going to increase your ability to see and do these procedures.
Correct.
Increase your case acceptance because
Correct.
you're hearing them, you're in their offices, whatever relationship you work out.
Correct.
So now let's take it from the flip side and focus on how can specialists increase their case acceptance? Because it's ironic, as we've done this season on case acceptance, we've built a course on case acceptance. It's almost like, from a specialist perspective, you're like a step removed. It's the GP a lot of times that can make or break whether the patient who's coming to you.
That's absolutely correct.
So, but that's hard.
That's absolutely correct.
You're relying on someone else to talk about your treatment.
That's absolutely correct.
And talk about the values and the importance of it.
Yes.
So that's a challenge. That's a huge challenge.
Yes.
How do you help specialists do this and
Absolutely.
get better at both their case acceptance in their office, but also helping their GPs get better at this?
The first thing I'll say is a bit of a visualization, if you will. So as a GP, I want you all to picture yourselves looking at your schedule for the day and you're looking at the patient's names. And you know immediately whether it's going to be a good day or not. Is that fair?
Yeah.
When a specialist looks at the patients coming in and then looks at the list of who referred to them, they know how good their day is going to be. Okay? So what you said couldn't be further from the truth and is one of the absolute top frustrations of specialists is how you refer that patient to them.
Yeah.
The answer is actually education. The answer is, like I said before, my favorite quote of Frank's, you only treatment plan what you see, you only see what you know. That extends to you only, refer what you see, you only refer what you know, both not only from a clinical diagnostic perspective, but also an understanding of the referral process and what the specialist needs, as Dr. Steve Rathko says, to do their best stuff. Maybe it was Gary DeWood. I don't remember, but I love that. Do your best stuff. So
I love Dr. DeWood. He would come to Midwestern at our dental school, and his wife was there and everything.
Yeah, they're awesome. So that's huge. And so what can a specialist do? The way, what we've observed over the last 3 years through the master's program. So we're now working with over 200 specialists.
Okay.
Oral surgeons, periodontists, and endodontists.
Okay.
And the way you actually improve case acceptance, and by the way, the way you also, particularly for surgical specialists, improve the complexity, the quality, the size of the cases for needed treatment is through education and interacting with the GPs in a very, very different way. So most specialists interact with their GPs, and I'm not talking clinical here for a second, but from a referral management perspective, what? They'll, send you cookies, donuts, they'll take you to a ball game, dinner. You may do a CE thing, but it's typically larger scale. They have nothing to do with what you're interested in. And what we've come to call that is more thank you strategies or rear view mirror strategies. You're thanking the GP for stuff they've already sent. Okay. But the reality is that if you can help the GP be better, if you can help their cases be more predictable, if you can help their team to understand the process in a deeper way, they'll grow, they'll start referring more, and you'll grow. Okay. And I can prove that because I can tell you that working with over 200 specialists, the average growth we've seen year over year is 20 to 30%.
Wow.
Which is insane.
That's crazy.
And it's interesting because it's not just more cases that are being referred, not at all. We're working with more seasoned individuals that have been in practice. Well, I'm sorry, we're working with both younger as well as seasoned individuals.
Sure.
And even the seasoned individuals that are booked out for weeks and weeks and weeks, the quality of the cases that are being referred by the GP end up impacting their practice so dramatically, they're seeing this level of growth. So the answer is understanding where that GP is in their journey, what the GP is looking to do, how you're communicating and referring back and forth, supporting them, the GP, to be better, and then you're improving as an end result. And we've seen it over and over and over again. And we do that through the platform of Spear, through our study clubs, through Spear Online, through patient education, which all of those three elements are contained within the study club from the GP's perspective.
Okay. So
they have the content from the club, they have the content from Spear Online that's inclusive of the patient education application.
So you would say that, and if I can summarize this back, rather than a thank you strategy of like, thanks for referring stuff, here's some presents, here's some food, helping them along their journey from a clinical education standpoint is like the best way to increase the quality and quantity both of referrals. How do you go about doing that? Like, if I'm a specialist and I've got a GP that, like, you know, they're just never looking beyond like one tooth. You know, they're just always sending over like, hey, you know, we need this one implant or we need this, but they're not really sending over bigger cases or other things like that. What's the conversation that you have?
Absolutely. Well, it all starts not at the conversation, but in preparation for the conversation.
Okay.
And what do I mean by that? So what we teach is that as a specialist, you need to look at who works with you. You need to look at what they're referring to you, but then you also need to look at who they are.
Okay.
And we call these personas.
Okay.
And so another way to put this is, what makes that GP tick?
Sure. What are they into?
What are they into? Are they totally clinically driven, 100%? Are they a bit more economically minded? Are they struggling and they're stuck in single tooth dentistry? Where are they?
Yeah.
So we take what they've been referring, who they are, and we help them organize that. We actually have an online tool, believe it or not, with a library of strategies.
Cool.
And so, you know, let's say there's a doctor that's struggling and they're having difficulty with case acceptance. You also happen to know, as a specialist, because you have somebody, by the way, on board called the professional relationship director, or as we call it, the PRD.
Okay.
That's the liaison to the GP. You also know that, you know, they're having trouble communicating with their patients. They're having a bit of staff turnover. So you go in there and you help to facilitate not only doctor to doctor with maybe some co-diagnosis like we talked about before, maybe with some over the shoulders, which we talked about before, but what about that PRD, that relationship director, going in and helping to facilitate a lunch and learn with the team on helping patients value and accept great dentistry?
Okay.
Helping understand how to get over the insurance mindset if that's an issue. You help the team do their job better. You help the team communicate better. You help the doctor communicate better. Holy smokes. Now the whole thing starts to elevate. Patients are get better care. GPs are busier. Specialists are busier. And that's why I get so excited to get up in the morning, because that's what we've seen over and over and over again.
Cool. So it becomes like, and this is ironic, because I feel like one of the keys with case acceptance for GPs and for everyone overall is that a patient can sense that you care about them, you understand their situation, and that you're acting in their best interest, trying to give them the best treatment.
Correct.
And people feel that. So you're saying that as a specialist, if you feel the same way towards the GP, and
great way to put it.
You care about the situation they're in, their practice, how it's doing, you care about what they care about.
Absolutely.
And you want to help them wherever they're at.
Exactly.
Then they're going to sense that.
Exactly.
And I also love that idea of coming in and training the team, because like everyone needs help training their team. And sometimes just as the doc, you're saying the same thing over and over and your team is like, yeah, no. And then someone else comes in and says it. Maybe they say it in a different way. Maybe they, you know, have different authority. And so having that additional help and backup from another, like, oh, wow, I guess everyone does it this way. We should totally implement this in our office.
And what I often say to specialists, and this is what we teach in the first workshop, is, you know, how a patient's referred is a reflection of your relationship with that GP.
Okay.
If that patient's referred, now there are certain exceptions, of course, but that's life.
Yeah.
You know, if you have a patient patients that continually get referred in a very poor manner from a documentation, mindset perspective, et cetera, how is that reflecting your relationship? And when you really sit down and think about it, you'll come up with your answer, which is probably kind of poor.
Yeah.
So,
okay, let's talk about, so building this relationship with the GPs and helping them where they're at is going to increase both their diagnosis and case acceptance.
Yep.
Now, let's take it back into the specialist office. So say that we're doing a better job of this. We're working on that, and the GPs are seeing more, diagnosing more, presenting how you would talk about things, and actually sending them to you specifically rather than just here's a bunch of cards.
Becoming, as we call it, the specialist in the community.
Right. Now let's take it back in the specialist office. And this is going to depend on the specialty. So whether it's endodontist, periodontist, oral surgeon, because it sounds like kind of what you focus on. What are some things that you can say to each of these specialties on increasing case acceptance in their offices?
Sure.
Do you have any specifics for any of those?
Well, I think it all boils down to everything that we just talked about.
Okay.
Because the reality is that how the patient presents is most of the
the work.
The work.
Yeah.
And so what we help to teach them as well is also how to be more efficient in their discussions.
Okay.
Because the reality is that if you talk to surgical specialists in particular, and you ask them, how long do you spend in your consultations with your patients? You'll get a range of answers. Some of these individuals are spending an hour with their patients. And the reality is that you need to spend time with your patient. But if you're honest with yourself, the question then becomes, how long do I really need to spend with my patient? Can my treatment coordinator, can my implant coordinator, can my office manager be communicating some of these elements that I don't need to do?
Yeah.
So that actually goes to more practice efficiency versus case acceptance. But I can tell you that with the hundreds of practices I've worked with, how they talk to their patients in their office is a much, much, much smaller element.
Okay.
Than how the patient is actually presenting to begin with.
Okay.
Hands down.
So then let's explore this a little bit then. How would you go about, say that someone doesn't have a treatment coordinator that's presenting treatment and maybe taking some of that responsibility.
Sure.
Or maybe they're overlapping the same things that you're repeating yourselves, or they could be using the videos. How could a specialist implement this idea better of having a treatment coordinator do everything that they possibly can and doing only the amounts essential to presenting this to a patient?
It's an interesting question, and ironically enough, it ends up being multifaceted.
Okay.
Because one of the elements they have to think about is what we call practice capacity. So practice capacity has everything to do with how many doctors do you have?
Yeah.
How many back office staff do you have? How many front office staff do you have? How many chairs do you have?
Sure.
So all of those things kind of feed into how you can have scheduling your patients, how efficient you can be,
okay,
and who needs to be involved in what part of the process. So as part of the workshop that we call Mastering the Exceptional Specialist Practice, that's the first step before they even go in the master's program. Because you could take the workshop actually as a standalone. You don't have to just say, all right, let me do the full bore thing right away. You don't need to do that. We actually teach you how to schedule yourself based upon real life examples from oral surgeons, periodontists, and endodontists, depending on the workshop you go to, so that you actually understand, okay, based upon my practice capacity, this is how I'm going to schedule myself moving forward. I don't need to be a part of the discussion in the beginning or the end part in terms of, data, some certain data gathering elements, as an example, potentially, as well as explaining next steps in the procedure, post-op, things they need to be watching out for, all those kind of things. A lot of those elements can be lifted off of the doctor's plate.
Yeah.
So again, it's more about tailoring it to their specific practice situation so that they understand how to schedule themselves, which we teach them as part of the workshop.
Well, and I think this also goes back to that conversation we had at the beginning of the specialist has team members that specialize in assisting and coordinating and scheduling patients there. So this really is where you can become super efficient because it's the same spiel. And
that's correct.
I realize this, like, it's hard having an assistant who does everything because they have to be able to explain the post-op instructions and everything for this versus that versus that versus that. Whereas when you have a specialist, you can really maximize that efficiency of your team.
And if you take endodontic practice as an interesting example, endodontists as a rule have a much higher case acceptance percentage than other specialties. Maybe not, equal to ortho.
I got halfway through my 2-year AEGD and I realized, I was like, maybe I should have just done endo.
Because the reality is that when patients present for endo to an endodontic practice, they know that's what they need.
Yeah.
Okay.
Yeah.
However, if you talk to endodontists and you say to yourself, okay, or you ask them, of the consults you had last week, how many of those shouldn't have appeared to begin with? Because had the GP been a little bit more aware, the patient wouldn't have presented to begin with.
Yeah.
And they typically give me a number anywhere between 10 to 30%.
Yeah.
So what I say to them is, think about it. You deepen your relationship. Now, all of a sudden, let's say now only 5% or 10% or 15% of those patients didn't go through, but an extra 5, 10, 15 did move forward. What would that do to your practice? And then their eyes open. So again, it has everything to do with how the patient is referred.
So, and one last thing, then we'll wrap this up.
Sure.
You mentioned this referral relationship person? What did you call him again?
A professional relationship director.
Professional relationship director. So it's interesting to me because when we were talking about someone who's presenting treatment in your office, that's dependent on the flow of your office.
Correct.
Whereas this professional relationship development is more dependent on, do you have someone on your team right now that's kind of doing this and needs to be developed more? Or maybe do you need to hire someone? Have you seen people where they've decided, I'm all in on this idea, let's bring someone in to manage these relationships?
Oh, absolutely, without question.
So what does that look like? Because I feel like one of the things that happens is a lot of GPs feel like it's just hard to like communicate with this specialty office. It's hard to get a hold of specialists.
Yep.
What does this look like? Who is this person, and how do you implement this professional development?
Absolutely. Professional relationship director.
Okay, there we go.
So, the first question that pops into a lot of specialists' mind is, what do you mean? I got to hire somebody else?
Yeah.
Or if they're going to, shall we say, transition somebody that's an incumbent member of their team and then back hire, like, how am I going to afford this?
Right.
Actually, it's scary how easily it is to be able to afford this position, because I want you to think of it this way. If your average case value in a surgical practice is about $2,500, just give or take.
Sure.
And this professional relationship director, if all they did was to facilitate one additional referred case a week, that was at, let's say, 80-90% case acceptance. So let's say 3 of those move forward. So 3 times 2,500 is what? 7,500. 7,500 times 12 months in a year?
That
do
pays
the
for
math.
itself. Yeah.
It's a non-issue when you do that. So that's an important first thing. This individual ends up functioning as the liaison between the GP practice and the specialty practice.
And let me ask you here, if you were to be hiring someone, like, who would you have in mind that, like, this used to be a front desk member or this used to be an assistant somewhere out? Like, who is the ideal, like, person to plug into this position?
The ideal person from a skill set perspective, believe it or not, is not somebody that already has dental knowledge.
Okay.
Which might surprise you.
Okay.
The person that is most successful in this role is the outgoing individual that's organized, that is open to coaching and growth, that doesn't mind being held accountable, and gets excited by helping others be better.
Okay.
So it's that it factor of personality and follow through.
Yeah.
Who's not afraid of technology to use various elements of technology. And the dentistry we can teach them.
Okay.
We actually have, as part of the master's program, a whole pathway to kind of get them up to speed, on top of course, getting to know the individual practice, specialty practice. Very well.
Perfect. So it sounds like once you can wrap your brain around, this person affords, like, they pay for themselves very easily.
Yeah.
Without, you add one case and then you increase the average value of all your other cases.
That's correct.
And that's where the true growth comes from there. So they pay for themselves. Now we understand who we're looking for, who the ideal fit is. So we're going to hire and grow this person. And then if you want to try and train this person in office, sure, do that. But if you don't, then turn around and use your guys' material, your training, your program.
Yep.
And then they have a template of how to do this, so they don't have to reinvent the wheel.
Not only do they have a template for training, don't forget that, once they're trained, now what do they do?
Right.
And so we provide this online tool called the strategic planning tool, where you actually put in the referring doctors' names, what they've referred, who they are from a persona perspective. Then you pick from this library of strategies, okay, what am I going to do?
Yeah.
And then we guide you with the planning process of planning each quarter, so you know what you're going to be doing for multiple touches with people within your referral base on a regular basis.
It's like a CRM system. It's like,
in essence,
almost.
It's more of a strategic. It is a strategic planning tool, because a CRM is a little bit more hefty.
Yeah.
But this is a goal setting planning tool.
Okay. And it gives them a framework to build off of and move forward with. Well, this has been awesome. I feel like we've covered a lot of ground from both a GP and a specialist perspective. And it's that scarcity mindset that if people can abandon and also be honest and open, I think there's fear too of just what's my specialist going to think, or what are these GPs if I try and teach them? And it starts with that mindset, and then it goes to these skills.
Absolutely.
And everyone benefits.
Absolutely.
If someone wants to reach out to you and learn more and kind of develop this, what would be the best way to do that?
Actually, I would say just simply go to speareducation.com. If you're interested on the GP side of our education, you can take a look at our educational platforms on campus, as well as Spear Online.
Cool.
If you're interested in the study clubs, you can look into the study clubs. And then if you're a specialist, all that, of course, applies. and then some under the specialist education area or specialist resources. There's detailed information about the master's program, both on the periodontist and oral surgeon side, as well as the endodontist side.
Awesome. Well, thank you so much for coming on the show, Dr. Martin Mendelson. Really appreciate your time and your expertise. This was a lot of fun.
Awesome. I agree. Thank you so much for having me.
Yeah, no problem.
Take care.
Okay, that was another fantastic interview from the people at Spear Education. Really enjoyed my conversation with Dr. Mendelson. Go on Spear Education online, check out either those learning resources, the courses, or if you're a specialist and want to try and implement this in your practice, the fact that they have this all built out and they've done it over and over means you don't have to reinvent the wheel. So I would 100% reach out to those folks, check out those resources online, and we'll have links to some of their stuff at Spear Education in the show notes. So another huge thank you to everyone who's left us a review on iTunes. We are now at 269, which is like 6 reviews behind Dental Hacks. So we're close to catching up to Jason and Alan here. Super grateful for you guys. Means a lot to us. It allows us to hire editors, get sponsors that we believe in, so that George and I don't have to edit these ourselves, or that we have resources to dedicate towards this, so we can keep the show going despite all of the craziness that we have going on. So really, really means a lot to us. Thank you guys. We will talk with you next week on the Shared Practices podcast.